Shift to video. Sometimes we can only repair one side. This is an example. In this case, I can repair only subscap and anterior part of the supra. For the posterior, I cannot repair it at all, so I can repair only the anterior part. Anyway, it's worked pretty well. For the clinical part of the repair technique, I think not just the partial cup repair. I think every option shows the better improvement of the treatment. Almost every option. But for the partial repair, it's good for short and midterm result. The repair rate is quite wide. It's vary from 30% to 70-80%. Like this paper from Dr. Moritz, he compared the patch graft with the partial repair. The patch graft show only 8% of the repair, while the partial repair show 40% of the repair. I did the study from 2014 to 2020. I have roughly 300 cases of the massive cup tear. 150 were treated conservatively. The other was underwent surgery. I did repair for 140. 7 cases I did reverse prosthesis, and 1 I did bilateral LD transfer. For the result of the study, I do MRI follow-up for every case that is available. So it's about 110 cases, which I did the MRI study. All of the 140 cases, no need the revision surgery. The shoulder score become better for every cases. For the repair, I think we cannot classify according to Sukaya classification because we repair it partially. It's not cover all the footprint. So I classify the tear in 3 types. First one is fully healed. Second one is partial healed. The last one is complete repair. This is the example of the fully healed of the repair. You will see a cup with a very thick tendon. So this is very good. This is another one, is healed, but the tendon is quite thin. This one has a small area of repair. And the last is complete repair. Anyway, I think even the patient has a complete repair, the clinical also pretty good. First, the pain must go away, and then we allow the patient to do physical therapy, to do the exercise, and the patient become better. So this is the healing rate result. For complete healing, I got about 45% of healing. The partial heal is about 25%, whereas the complete repair is about 28%. Anyway, every cases have a good satisfaction. For double row, may heal a little bit better than the single row repair. For the strength, it's improved about 1 manual muscle testing grade if the tendon is healed. For the muscle atrophy, at 1 year period, which is I did MRI, no muscle improving because I think it's still very short time to see the improvement of the muscle size. For all the case, you may find the worst result if the teres minor has a atrophy like this one. So if the pre-op MRI show big size of the teres minor, you may think and may can predict the good result from that. In 2018, I attended CLAAS meeting. Also, I think at that time it's at Phuket. So I meet Professor Kim. Yeah, he showed the bicep rerouting technique, which is interesting. In the past, the bicep is like my enemy. It's like a source of pain to me. At that time, I just cut it away and rarely do tenodesis for this kind of cases. But after that, after 2018, I decided to do augmentation to the repair site by leave the origin at the supracrineal tubercle intact, and then I cut it at the bicipital groove and move it to the repair site. And I think because the blood supply is in the origin, it might help for the repair. Anyway, I think it might be another source of pain in the future. This is how I use the bicep in rotator cuff repair. This is I pull the biceps and I do the groove tenotomy and mobilize to the defect. And then mostly I repair side to side with the bicep in the middle. At that time, we don't have the one-knot flex, but right now I use it quite a bit, and it's quite strong. I agree to the presentation you show us before. And I did the side to side for the rotator cuff after I fixed the bicep. So this is a final repair. This is the diagram of the repair. I put one anchor in the back and one in the front, and then repair rotator cuff with one limb of the suture and the other limb of the suture to the biceps, like this. In some cases, if the tear is a little bit bigger, so I might use 3 anchors instead of 2. I did a review for the bicep SCR, a few biomechanics study. Anyway, in 3 or 4 studies show the bicep is another good support for prevent superior migration, but it's a time zero study. Because every study is did in the cadaver. So how about the clinical result? From past few years, the clinical result is not showing about the bicep SCR. It shows just a bicep rerouting technique from a Korean group. It's about 3 to 5 year result, but they show the outcome is pretty good with low repair rate for the SCR, the bicep rerouting, I mean. And the result is depend on the quality of the bicep. If the bicep is still good, not partial tear, the repair is quite low. And also from Professor Kim, he did a study about 2 to 4 years for his cases. The outcome is improved for pain, range of motion, and the AHI is decreased with about 25% repair rate. About my series, I did about 3 years for the bicep augmentation, about 40 cases. I have the 10 cases that's healed perfectly. The other 5 has a partial heal, whereas the complete repair is 3 cases, and the other 12 wait for the MRI study. Every case has a 90% satisfaction. The pain was improved, the function improved, and still no need for revision surgery. This is another case that I did MRI. We use bicep to augment the repair, but this case I think I maybe repair it a little tight, and would like to have a tenodesis effect to pull the head a little bit in abduction. But in this case, show the hypersignal at the supraglenoid tubercle. That's been this case is healed, but because the tension at the origin is quite high, so I'm not sure about the late result of this case, but he's still not showing any pain and still have a good function. So I just wait and see. What we expect from arthroscopic partial cup repair, we can improve the pain by synovectomy, vasectomy, improve the weakness by allow the tendon to heal, and in case of the stip, we did a capsular release and do a physical therapy after surgery. So I think the roll up the bicep in partial cup repair is quite easy to do. We can close the tendon gap with adding the bicep to the gap, which I think it might augment the healing. For the tenodesis effect, we still need to see whether it can help for the tension of the bicep or not. From my study, I think even the patient have a retear of the bicep. The clinical is still good, so I'm not sure about the bicep is really help for the repair or not. We need further study. And the take-home message, I think, for arthroscopic surgery for massive irreparable cup tear, either repair plus or minus augmentation, I think it still play a major role in my practice. About 80% of my cases still be able to treat using the arthroscopic means. This has a less invasive, low cost compared to the reverse prosthesis. It showed a good midterm result and can restore the force couple balance. Thank you, and hopefully can see you all in next year at Pattaya for the TOSM and APCATS meeting.
Thank you, Dr. Tirapan. Next, we will have Dr. Chiu from Taiwan present on his topic.
Hello, everyone. Good night. And can you hear me or see my slide?
Yes, we can hear you and see your slides.
Okay. I'm very impressed about the last slide because we all plan to go to Pattaya in, I think, in the middle of 2020, but because of the pandemic, we can do it. So we hope we can see each other next year. Okay. And okay, by the way, I'm Dr. Chihao Chu. Okay. My topic today will be from SCR to tendon transfer, my way to treat the irreparable rotator cuff tears. I should modify the topic because if there's some osteoarthritis, I will go straight ahead to reverse. So my topic is focused only on the shoulder without osteoarthritis. Okay, I'm from Changchun Memorial Hospital, which is the biggest private system in Taiwan. Our hospital have many trains all among Taiwan, and we cover like 10% of the medical expenses of Taiwan. So we are very welcome you if you want to travel to Taiwan. We have good food, just like Thailand, just like Korea, and we are very hospitality. Okay, and like to see you all. Okay, because today I think most of the attendees are very professional. So I just try to introduce my way to treat the irreparable cuff. Okay, for me, I only do cuff repair below the Grotalia grade 2. Okay, because once if you have like more than grade 3 fatty infiltration, you're doomed to fail. According to Ahong Goldenchi, on his 10-year follow-up, if you have the stage like grade 0 fatty infiltration, you'll have like 10% of repair rate in 10 years. But if you have stage 1, the repair rate of supraspinatus will be 22%. And if it's a Guatelier 2 fatty infiltration, the repair rate will be 30%, which was not allowed for the modern treatment. Okay, and this is in France, but which was worse in Switzerland. Okay, this is this report by Dominic Meyer and Christian Gerber. They think that if you have a Guatelier stage 3 fatty infiltration, the repair rate will be 100%. And they also look at the tendon remnant, and if the tendon length is like less than 50 millimeters, so the repair rate will be even higher. So the primary repair may not be enough for some times. So there are a lot of methods to treat the irreparable tears. So you can see it's a busy slide, and I have tried most of them because according to Berhard, in 1994, he invented the first couple theory, I think, which is very useful and very practical until now. You can just do a partial repair with a balanced subscap and infraspinatus. You centralize the humeral head and you train your deltoid, and yeah, you will progressively improve, but not always. Okay, so I've tried a lot of like just what we just discussed, the medialized repair, margin convergence, try to repair subscap as much as possible. Okay, and just try to repair everything. Okay, whatever inside the joint. Okay, at past we used to cut the bicep because it's a pain generator, but now we see there's a more and more studies utilizing the biceps as a graft. I think it's a very strong graft, and it's a strong and an easy graft because it's already there. Okay, so like 10 years before I do like this. Okay, and after 2012, thanks to Dr. Mihata, who invented a very nice idea of superior capsule reconstruction. And then we started to do a lot of superior capsule reconstruction, like the Mihata method. Okay, and according to his idea, the indication should be Hamada 1 or 2. You shouldn't do it on Hamada 3. Okay, but from time to time I do it, or if it is a revision surgery. Okay, so in the past I use Dr. Mihata's technique. I use the iliotibial band, which is very strong because according to Mihata, it should be like 8 millimeters thick. Okay, the thicker the better, but I think it's very difficult for me to put such a thick graft inside the joint. Okay, so the Americans, the Berhard, they use like aerograft, thermometrics, which will be easier. Okay, so in the past I use the IT band shuttle inside the joint. Okay, actually the result is not bad. Okay, like the wound is like this. It's a little bit bigger. Okay, the problem for me is that if we use Mihata or even Berhard's way, we have to use a lot of anchors, and in our medical system, the medical insurance only cover part of the anchors. So if you do a Mihata superior capsule, we'll like flowers inside the hand. You use a lot of anchors, and the graft is expensive. In 2018, I have my fellowship in Switzerland with Dr. Alex Lederman in Geneva, And actually, he is not a big fan of superior capsule reconstruction the Mihata way with the IT band. So when I was with him, we seldom do the IT band superior capsule reconstruction. And during my fellowship, I travel and I visit Dr. Young Bars, who invented a very clever way, just use the biceps, which is very common now. Okay, he used a suture-based anchor to do like 3 lasso loop and repair the subscap and the infraspinatus to cover up the biceps. We call the biceps. He called it the bicep SCR. Actually, because Dr. Young Bars was I think he's a traveling fellow and to Asia, and he visited Dr. Shi Chen and discussed a lot of bicep treatment with him. So he said that it's a Chinese way, okay? But I know we can see that now it's a global way to treat the massive cuff tear because the bicep is a very available graft. It's just there, okay? According to Young Bar's data, he had like 28 double row repair, 30 transosseous equivalent repair plus patch, and 21 bicep SCR. And according to his data, the 3 group was comparable but for flexion and tendon retraction. The patient who received the biceps FCR has worse for flexion and the tendon retraction before the surgery. However, the result is very promising. Their data reveals that the bicep SCR can help the supraspinatus and the infraspinatus healing, okay, compared to double root repair, traditional double root repair, and the transosseous equivalent, even plus a patch, okay, which he used an ultrasound to evaluate, which was very promising. So after that, when I came back Taiwan, I just started to do my series of bicep SCR. This is a 60-year-old male technician. Actually, he's a MRI technician of our hospital. He still plays basketball in 60. Okay, we can see there's a massive cuff tear, anterior superior cuff tear. The biceps is okay. Okay, the posterior cuff is okay. So by the time I think it's the best indication for biceps SCR. Okay, and actually it's easy. We can see he got some slab. The subscap is okay. Okay, the bicep is strong and inflamed because he got an acute tear. Okay, we can see a huge tear. Okay, we debride the footprint. Okay, we try to mobilize my biceps. Okay, this is a nice biceps, and actually the anterior cuff is like a little bit stiff. Okay. So my plan was to like reroute my biceps posteriorly and covered my infraspinatus anteriorly, okay, which was actually it's very common now, okay. I use an all suture anchor or whatever, okay. Actually, I like to use the Why Not RC because it provides 3 strands of sutures. I normally use 1 or 2 of them, and the other strand we can use for the cuff repair. Okay, I do a lasso loop. I do a loop outside the joint, which is easier for me. Okay. Okay, here's a lasso loop, and I penetrate the biceps. Okay, I do like a 2 biceps. Okay, according to the time. Okay, you can skip the other video. Okay, because the patient is he's a technician of MRI, so he can do MRI follow-up whenever he wants. So we seldom do the MRI follow-up at 1 month post-op, but because he's working there, he just do it like every two weeks. Okay, this is what the bicep SCR looks like in post-op 1 month. Okay, you can see that the cuff is repaired and the biceps. Okay, the footprint is almost covered. Okay, and now it's only like it's already 9 months, and he came back basketball. Okay, so we know that the biceps is very popular graft. Even someone even just have triple bundle long head biceps graft. I think it's shocking for me. I think it's not easy, but yeah, there are plenty of ways you can do. Okay, you can reroute the biceps, you fix the distal part, or yes or not. Okay, and you even don't cut the distal part. Okay, that's fine. Or you make a loop, you make a triple bundle. Okay, but for me, I use the most easy one is the A. Just reroute the biceps posteriorly, and we left the distal part alone. Okay, so I have done plenty of bicep SCR, and I'm satisfied with the result. But when I think about the idea of SCR, I always think about Mihata's such comment, like the success of SCR lies in the thickness of the graft and the coverage of the graft. Okay, so the Mihata's SCR, you need a very, very thick graft, and for like a Berha SCR, the graft is like 4 to 5 millimeter, which is less, of course, it's less thick and easier to introduce. And for biceps SCR, it's even easier because you just reroute the biceps, and that's it. And one time when I was jogging, I just wondered, why should I do an thermal allograft plus a bicep SCR? Okay, then I just trying to do it. Okay, you can see it's a Couturier 3 cuff, massive cuff tear with subscap tear. Okay, I use a thinner allograft because it's cheaper. Actually, it's because it's cheaper in Taiwan. Okay, it's a massive tear. Okay, massive tear. Okay, and the biceps is okay. You can see the supraspinatus is difficult to reduce. Okay. Again, I reroute my biceps posteriorly. Okay. I do a lasso loop, just like the biceps CR proposed by Young Bars or by many other experts. Okay. I make a loop, and okay, and for me it's because the biceps is normally it's like a 5 to 6 millimeters thick, and if I can put a thinner graft, like a 2 millimeter thick graft, it will be like it's a easy simple math. It will be like 7 millimeter, which is close to Mihata's 8 millimeter graft. Okay, you see, the bicep is strong. Usually, it's very strong. Okay, the probe is like 5 millimeters, so you can see the thickness of the biceps is more than 5 millimeter. Okay, then I do the distal tenotomy, and I didn't fix the distal part of the biceps. Okay, just like the bicep tenotomy, which will like a kind of bicep killer to relieve some pain. Okay, you can see it's a very thick graft. Okay, then I do like 2 lasso for the bicep SCR. Then I put this a thinner SCR, cover up the biceps. Okay, the biceps is done, and then I put 2 anchors in the glenoid side, which is a double loaded anchor. You can see it's a why not flex, which is I think it's very good because it's small. Because we oriental people had like smaller glenoid. So we know that John Turkish, they use 3 anchors in the glenoid side, but the people in Taiwan are smaller, so I only use 2. Okay, I use the traditional, very conventional double pulley technique. You see the graft is not so thick, so it's very easy to introduce, and with the very regular wound, the smaller wound. Okay, you don't need the passport trocar. You just I don't need a trocar to finish the bicep SCR. Okay, then I fix the granule side of the graft. Okay, you see the tension is very good. Okay, then the final tension is determined by the position where I fix the dermal allograft. Okay, so I skip the medial row of the SCR because I can save like 2 anchors. Okay, you see. And I use a 3-lock. Of course, if you want to use a pop lock, that's okay. Okay, the tension can be determined by where you put the lateral anchor. Okay, so you don't need. You see the tension is good, and the biceps is just underneath the dermal allograft. Because for me, the SCR is like to provide the spacer effect. Okay. The remnant suture, the infraspinatus can be pulled anteriorly from the lateral anchor. Okay, this is the final construct. We reroute posteriorly the biceps. We cover the biceps with a dermal allograft, and we like to extend the infraspinatus anteriorly. The final construct will be look like this. This is an intra-articular view. Okay, it's almost fully covered. Okay, this is a case. Okay, pre-op, I think it's a Hamada 2. It's not so bad. Okay, actually the AHD cannot be improved so much after surgery, but you can see the clinical result is okay. Okay, it's not bad. External rotation is good. Okay, internal rotation is not. We don't say perfect, but it's acceptable. He's a 45 years old chef, and because he is very very demanding. Okay, we can see from the ultrasound follow-up, we can see the biceps SCR and the cuff, the infraspinatus is covered anteriorly, the soft tissue, so almost fully healed. Okay, but I only do SCR if the patient are without leg. But if he had leg or external rotation leg, I don't do SCR, because for me, SCR is is a technique just to reduce pain. We know that the best result of the SCR like 70% satisfaction. Okay, so if the patient have external rotation leg, I won't do SCR. I will do tendon transfer. Okay, my idea I do my surgery according to the master's idea. So I use Dr. Pasabualo's idea, the Eiler, and clear. Okay, for isolated loss of elevation, I do a reverse. Okay, but for isolated loss of external rotation, like this guy, okay, I will do a tendon transfer for this guy. Okay, you see, loss of external rotation, but he still have very good forward elevation. Okay, so that's the best indication to do external rotation tendon transfer. Okay, and of course there are always some like complete loss of elevation and external rotation, and then we do a reverse. Okay, so I use Dr. Christian Gerber's idea. If the tear is irreparable, his functional demand is high, and if he had the pseudoparalysis in external rotation, Dr. Gerber will do actually Dr. Gerber will do a LD transfer. Okay, but if it's a pseudoparalysis for anterior elevation, he'll do a reverse. Okay, if it's a elevation and external rotation leg, a reverse plus tendon transfer. Okay, and Dr. Gerber is the proponent of lattice lat dorsal because it had the most excursion. Okay, so but for me the wound is a little bit too big, so I am now a fan of Dr. Bassam Ahsan, because we have a lot of this discussion. Now I use his technique. Okay, for massive irreparable posterior superior cuff tear, of course, Christian will do a leg transfer, but some will do a lower trapezius transfer. And for me, the lower trapezius is much easier than the left dorsal. Okay, so yeah, again, the data from Bassam, the ER1 is best in lower trapezius, and the ER2 is comparable between the left dorsal and the lower trapezius. Okay, so this is another study from UC Irvine, Dr. Taeku Lee. It said it's in 2015. The lower trapezius can correct most of the anterior shift and the superior shift. Okay, so they concluded that the lower trapezius transfer is stronger than the left dorsal in restoring the glenohumeral kinematics. So I'm comfortable with the lower trap. Okay, Bassam have published their technique. At first, they use a vertical incision to harvest the lower trapezius. Okay, like this. You can check it on the internet. Okay, actually they got a very nice video. Okay, now they use a horizontal wound. Okay, because it's easier to find the medial part. Okay, and thanks to Bassam's video, it's his video. Okay, and I think you can discuss with Bassam about his technique. He used an Achilles allograft and used like a swift lock and use an on-leg fixation. Okay, I think it's great, and from time to time I do these techniques. Okay, but because of time, I can move to my technique. Okay, I use for me, I use semi-tendinosis for the lower trapezius. I will discuss why I use this technique. Okay, this is a 60-something gentleman. Okay, you can see there's no osteoarthritis, irreparable superior posterior cuff. Okay, I harvest the lower trapeze first. Okay, because I also do some ACL reconstruction, so I'm familiar with the semitendinosis. Okay, harvest, and I do a bicep SCR. Okay, just like we just showed. It's a easy and simple technique because it's only take 5 minutes to finish the bicep SCR. Okay, and I use semi-T because the best reason is that because it's cheap, because you don't have to pay for the graft. Okay, and it's autologous. Okay, it's supposed to heal better than the allograft. Okay, okay. Now I finished my SCR. I finished my biceps SCR. I will try to open the bicipital groove because I use the endo button to fix my semitendinosis graft, and we know that the bicipital groove is the most strongest part. So I reroute my biceps and I clean my bicipital groove, which will be used to shuttle my endo button. I use the endo button rather than the sweep lock because I want to make it like an ACL. I need the inlay fixation. Okay, and I drill from the behind, from the footprint of the infraspinatus to the bicipital groove. Okay, if you do ACL surgery, it's a very common technique. It's a use the endo button. Okay, just use, but be careful because in ACL reconstruction we do the surgery on young patient, but for this kind of patient, the age is older, so you have to be very cautious during the tunnel drilling. Okay, it's a 70. I use it like a 2 loop. Okay, the build that I shuttle the endo button from the behind through the tunnel we just drilled. Okay, so now the semitendinosis works like an infraspinatus. Okay, then I pull in front of into the bicipital groove, and I flip the endo button. Okay, The beauty of the surgery is that you can control your tension. Okay, you can see it's a double loop semitendinosis working as an infraspinatus. Okay. Okay. Of course, you can always repair the remnant anteriorly to cover as much as possible, but most of the time it's difficult because, yeah, if you couldn't repair the cuff, you don't need the lower trapezius. Okay, like this. Okay. So instead of Bassam's technique, I use the endo button to fix the graft. It's an inlet fixation. Okay, and I also do biceps SCR along with the lower trapezius because I need to clean the bicipital groove, and it's easier to fix the endo button. You can see very good external rotation. Okay, the HD is not so good. I have to admit that, but the function of the gentleman is good. Okay, this is another guy. He's already 71. You see the X-ray is definitely a reverse candidate for reverse, but he's a mechanics and he want to go back the very heavy work. So I discussed with him, and I told him that you have to retire after the surgery, and he don't like it. You have to work for his family. So you can see that he still have a good elevation. So I do a lower trapezius for him. Okay, but even with his kind of superior migration, but sometimes from time to time we see patients with superior migration but still have good elevation because they may have very good deltoid, okay, or very balanced shoulder. Okay, so the cartoon figure will be like this. I use a autologous CMT, and I fix with the endo button, and I reroute my bicep posteriorly. I call it lower trapezius plus the bicep SCR. Okay, and after the surgery, we gain some AHD. Okay, not good but acceptable. If it's an anterior superior cuff tear, in the past, Dr. Gerber just used a pec major transfer, okay, beneath, in front or beneath the coracoid. But Bassam used a LD transfer, which I think is easy and is rational. Okay, so this is a 73-year-old female patient with a massive cuff tear. We can see before the surgery, her range of motion, her forward elevation is okay actually. Okay, external rotation is good. Internal is difficult internal rotation. Okay, you can see positive bear hug. Okay, lift off, positive lift off, but the external rotation and home blower are all normal. So okay, you can see her MR is a massive anterior superior cuff tear. Actually, you can see that his T1 is almost without the subscape. Okay, so I do a bicep, I do it open. You can see the supraspinatus is okay, and the lady had the hypertrophied biceps. Okay, I try to reroute the bicep posteriorly, open, like the open surgery, and I harvest the LD. I do the Bassam's technique. Okay, it's not special. It's just Bassam's technique, but because I have to finish the whole story. Okay. Okay, her subscape is gone. Okay, we can see she still have a very beautiful pec major, and the LD is just underneath the pec major. Okay, and then we harvest the LD and we try to pull as high as possible. Okay, maybe over the bicepsal groove. Okay, repair with the supraspinatus. Okay, just to restore some anterior fulcrum, like this. Okay, the final construct will be like this. You maintain you reroute the LD and you maintain the pec major. I think it's a good technique, and thanks to Bassam. Okay, like this. So although I have done so much tendon transfer, but every time when I try to do it, I think about my mentor, Dr. Alex Lederman. He always said that tendon transfer is useful when it is not needed. So I don't know. Actually, I'm a reverse guy. I'll do whatever I can do to put a reverse on the patient, but sometimes you do think tendon transfer works in some patient. Okay, so in conclusion, how I manage irreparable massive rotator cuff tears without the osteoarthritis. If he or she is a happy patient, I just do mental support. Okay, if the patient has good active range of motion only with pain and good AHD, I will do a dermal allograft SCR plus biceps SCR because it's easier and subscap repair as possible. If he is either isolated elevation, isolated loss of external rotation, I use a low trapezius with hamstring, but sometimes I use allograft, Achilles allograft. Okay, like this. I think it's an easy and efficient and cost-effective way to do the low trapezius. And if it's an isolated loss of anterior elevation, I do a reverse. And if it's clear, of course, reverse plus the tendon transfer. But I think that's not the topic today. Okay, but for if it's an anterior superior cuff tear, I do a LOD transfer for subscap. Okay, thanks for your attention.
Thank you for your presentation, Dr. Chu. We will now move on to the Q&A session. We have a couple of questions that we want the panel to answer first. So the first question that we have over here is, how do you determine if the biceps tendon has a quality sufficient enough for augmentation? So I think this one is a question for Dr. Kirapan in terms of your biceps augmentation.
I think both of us talk about bicep SCR, so I think maybe we can share the answer. To me, I think the quality of the tendon, if it's more than 50%, it should be okay. To me, I think it's like a graft that instead of just tenotomy, just use it as much as possible. That's it. But I don't really rely on the biceps. To me, I think the rotator cuff is the main structure that we need to fix it. That's just the main reason. So it's like an add-on graph. How about you, Dr. Chu? What's your rationale?
Yeah, I have the same idea with you, because sometimes we see the biceps is not as good because it's like delaminated, and that's why I do for like massive tear. I used to do biceps SCR only, but if the cuff is very bad, I will do a thin dermal allograft augmentation along with the biceps. In this technique, I can forgive the biceps if it has like a 30% partial tear. I don't care. I just reroute the biceps and I put I augment it with a dermal allograft. So actually, I have no answer for how much biceps is enough for the SCR for the graft. So I just use another graft to compensate for it.
Thank you. The next question we have is about the SEMI-T graft for SCR reconstruction. I think this is, I think Dr. Chu talked about using the SEMI-T. So that is, if that is your preferred graft, why is it?
Should I answer first? Okay. For me, because I do ACL too. Actually, I do ACL and ALL, and this is a very fancy technique. So it's a very friendly tendon. I mean, the SEMI-T is a very friendly tendon for me. but I use CMT for lower trapezius transfer, not for SCR, because I think the bicep SCR is more easy and cost effectiveness is better, because we can only use one anchor to do the bicep CR. Okay, if you want to use a CMT, at least you have to put like at least 2 anchors, one in the glenoid and one in the humerus, I guess, because I never do that. Okay, so I'm a simple guy. I just use the easiest surgery. Okay. So yes.
Oh, that's good answer. I do knee surgery too. I quite familiar with the harvesting of the CVT too. But to me, my indication for repair the cuff is quite broad. So in your talk, you choose so many options of the surgery. So that's very interesting. But to me, the repair and the SCR is work well in my hand. So very few cases that I decide to do some other procedure like a tendon transfer or the fascia lata SCR. So right now it still works well with this technique I presented. But maybe in the future I would try your technique.
Yeah, it's actually simple, and I think it's worth trying. Okay.
Thank you. On number 3, we have, would you do a cuff repair for a partial bursal tear less than 50% if the patient has no symptoms?
Me first. Okay. I don't do surgery on patient without symptoms. Yeah. Even if, yeah. Okay.
Okay, please go on.
Oh, no. Excuse me. Even if it's a full thickness tear, I'd rather discuss with the patient if they don't have symptoms, because according to my experience, the first 6 weeks is very troublesome, because there's a inflammatory phase have to going on for the patient, and they will have like difficult to sleep, and they will blame you about they will blame you about the 6 weeks right after the surgery if they didn't have symptom before. So I seldom do surgery for patient without symptoms. Yes,
I totally agree. That's my rationale too. But the other things we need to tell the patient that the tear may have a chance to progress or it stay like this. But mostly I let the patient choose. But like Dr. Chu told us, if the patient has no symptom, I don't touch the patient also.
yes. And if it's a bursal site tear in old patient, I will be more conservative. But if it's a articular site in a younger patient, I'll be more aggressive, because we know most of the tension lies in articular site. So yeah, it depends. But I think most patients they do have symptoms. Or why do they come to the hospital, right?
And I saw your slide. You didn't do acromioplasty. Is that correct? The one you show us.
Yeah, most of the time, yeah. Only for most of the time I do the acromioplasty, except the traumatic tear in younger patient. If it's a traumatic tear, I try to restore whatever they had, and I don't do acromioplasty for massive cuff tear, because I want to restore the arch. And once you you kill the CA ligament, there will be anterior superior escape, and so that's a disaster. You just go ahead to do the reverse. And so I try to preserve the arch as much as possible in massive cuff tear.
Great. The next question is, would you release the transverse ligament, humeral ligament, when rerouting the biceps? Are there any negative effects associated with it? I think this is regarding the biceps rerouting.
Yes.
So perhaps we could have Dr. Kirapan answer first for this.
I don't release the transverse ligament. I just pull the biceps as long as possible and just cut it at the groove. That's it. If you cut the transverse ligament, it may have a chance of bleeding. It's a lot of blood supply there. So if you don't necessarily, I think it's not necessary to do that.
Mm-hmm. Yes, I agree. There's two. I think there's another question. Just do you fix? Do you fix or do you cut the distal part of the biceps? And I think there's a Dr. Chunyuan Jiang from Beijing, and he published his study in arthroscopy in, I think, in 2020. He proved that if you reroute the biceps posteriorly, the tension of the biceps will be larger, so which may cause some pain for me. So I always cut the distal part of the biceps after the rerouting, and normally I don't release the transverse humeral ligament in the bicep SCR unless I have to do low trapezius. I have to clean up my bicipital groove. And for me, it's easier to see how the endobutton coming out. Otherwise, I don't release the transverse humeral ligament.
Great.
Thank you. The next question, number 5, is, I think it's a general kind of opinion for the type of anchor that you would use for either partial repair or in the case of an SCR. So maybe you could have Dr. Chu first for this question.
Yeah, I know it's of course it's a common limit symposium, but I do like why not, because in Taiwan and the why not RC, they can provide like 3 strand of suture, even 3 strand we call ribbon, or yeah, it's just fiber. It's a thicker suture. So for me, it's not only for irreparable cuff tear. For normal cuff tear, I use why not RC because I can use 1 strand to fix the biceps, okay, and the other 2, I still have the other 2 strands to fix the cuff, and I do a double row repair, and I do we call independent double row or conventional double row, and all kinds of that. So the why not RC can provide me a more flexible choice to fix the cuff. And as for SCR, it's even better to use a why not flex because it's only 1.8 millimeter and it's double loaded. So for people in Taiwan are relatively smaller than people in States. So if I put too much anchor, or if I took big anchor inside the glenoid, I am afraid there's cause some fracture or inadequate place for anchor placement. So I do like the old suture. I do like suture based anchor for every cuff surgery. Yeah, every surgery.
Yeah. My choice is quite similar to you. If I can choose one anchor, I will choose the soft anchor first. But anyway, I think we better prepare the soft and the hard one. Sometimes if we decorticate too much and the subchondral bone is not that good, so in that case we may need the solid anchor to put it a little bit deeper.
Yeah.
Great, thank you. We just had one more question come in just now. I think it's more of a, I guess, in a statement, but number 6, multiple fixation points only can hold the tough SCRs. So I think this question was saying that a tough graft will be needed for a multiple fixation repair for the SCR. Any comments on this, Dr. Kirapan?
Multiple fixation point only. I'm not totally sure that is I'm going to answer this question correctly. But for the bicep itself, it's very thin and not that strong tendon. If you're talking about the fascia lata SCR, maybe you need a lot of fixation point. Yes, I think that's right. But for the bicep, I don't think we don't need that much fixation point.
Yeah, I agree with Dr. Kirapan, because if we use a biceps SCR, we know most of SCR like IT band SCR or dermal allograft FCR, the most failure part was in glenoid side, right? And if we use a biceps SCR, the glenoid part of the biceps is intact from your mother, right? It's the strongest graft. It's even you can't beat the mother nature. So it's easy. If you use a biceps CR, we use one anchor, we remove the biceps. That's it. Okay, we don't care about the glenoid side failure. So for biceps CR, I think it's a simple, easy, and it's you can see there's more and more publication about this technique, and it's useful. And before we think biceps is an enemy, we like a pain generator, we have to kill it. But now we think like it's a friend. So we call it a paradigm shift. But for me, if it's dermal allograft SCR in Minhata or Berhart's method, they use like at least 6 or 7 anchors. Like anchors, you can think of it's a fixation point. So there will be 6 or 7 fixation point. But I do the thinner dermal allograft SCR along with the biceps SCR. So I only use 4 fixation point for my dermal allograft SCR, 2 in the glenoid side and 2 in the lateral row. Because in the medial row, I have a biceps SCR, which was very strong. So I don't care. I can save some anchor, which means I save some money and time to produce at least 7 millimeters of thickness. 7 millimeter is 5 millimeter for biceps and 2 millimeter for the dermal allograft. And it's easier because if you shuttle a very thick graft inside the joint, for me, it's a trouble technique. So I choose to do this easier. As I just said, I'm a simple guy, so it may be a simple surgery for me in my hand.
Thank you very much, Dr. Chiu. I think that was the last question that we have from the participants. If we have any further comments or any maybe questions you want to ask to each other from the panel.
I have a couple of questions to ask Dr. Chiu. From your talk, it's very interesting that you don't do repair for the massive cup with the high grade of muscle atrophy, right?
Yes, excuse me, the reception is not good. Can you repeat the question again?
I think from your talk, you mentioned that if the patient has a high grade of the muscle atrophy, like grade 3 and 4 238, you don't attempt repair, right?
Yeah, I will do partial repair with biceps and thermal allograft FCR, and I don't think I can repair it to fully cover the footprint in my hand in grade 3 fat infiltration. So I'll do whatever augmentation I need. Yeah.
Or maybe shift to reverse, right?
Oh yeah. I like reverse. I like reverse. Everyone likes reverse.
I think. Yeah, me too. I think it's the beauty of the massive cup tear because the same patient we have a lot of different idea. I myself I do repair even though the patient has a grade 3 and grade 4 muscle atrophy, but some cases they still work well after surgery. The other one you mentioned about the patient with leg side positive, you're going to do a tendon transfer, right? Can you hear me?
I'm sorry. It's sorry about my reception. Is I think it's my part. The problem.
Maybe I think maybe my internet is not stable. Sorry. My question is about the patient with the leg side positive.
Oh yes.
You don't try repair, right? You're going to do a tendon transfer right away.
Yeah. If the patient have external rotation leg, I'll see the demand of the patient, the age, and if he's a relatively young guy, I'll try to do lower trapezius. Yeah, and we can always do. In like 3 years ago, I haven't tried lower trapezius. I just do an infraspinatus repair. I think the result is okay, but actually, after I talked with Dr. Bassam Eckerson, and I think it make me feel more comfortable with such a strong graft. So and so I'm more aggressive with the low trapezius now.
I see. In my series, I think that's the point you mentioned is quite interesting because my series with the patient with the leg side positive, I did a repair. It's about 50% of the case can convert from positive to negative.
Yes. Yeah. So yeah, actually, I will see the muscle quality of infraspinatus actually. So if criteria 2, I'll more favor a lower trapezius. Yeah, maybe because my training background, and I'm maybe too much influenced by Bassam. As Dr. Lederman, I'm a fellow of Dr. Alex Lederman, and you see my slide. It's a joke, but he seldom do tendon transfer, and he thinks reverse is stronger than tendon transfer. So sometimes we just have to like make our own decision for our patients.
Great. I think some patients really need tendon transfer, the young one.
Yeah. Okay. And I don't do reverse for patient with good range of motion. So I have shown my slide that the 70-year-old gentleman, he owns a car company. So he have to work for his family. So he can do a reverse and retire. So for this guy, I do a tendon transfer. But I think 90% doctors see the X-ray will decide to do a reverse.
For reverse, right?
Yeah. Actually, when I go inside, I regret to. I promise. I want to do a reverse, but if I still do a low trapezius, and he's happy about that.
Okay, understand.
So,
but it's worked well, right?
Yeah. So I think surgery is an art. for me.
Yeah,
It's an
agree.
art. Decision making is an art.
Okay, if there are no further comments from the panelists, I think we can call
Excuse me.
this-
Can I have one more question?
Yeah, of course.
Yeah. Dr. Kirapan, I think you have done plenty of margin convergence. Do you still
Yep.
do interval slide?
That's the point. I still do for the anterior part, but not the posterior slide.
Oh, cool. Okay.
I don't do posterior slide anymore. I think it's very aggressive way, and it doesn't work well in my hand.
Okay. Yeah, but for me, margin convergence is like the opposite of interval slide. I don't know. Maybe next time we see Dr. Berha, we can ask him. Yeah. So I seldom do interval slide too. I think if it's repairable, it's repairable, and if it's not repairable, we do a superior capsule. Okay, or lower trapezius.
I agree, because I think the release, especially in the back, is not anatomical repair or reconstruction. To me, I prefer to do just anterior slide. That's,
Yeah.
and maybe go for the SDR, maybe better option.
Yeah, I agree. I totally agree. Thanks for your good talk.
Do we have any more comments from both the panelists? If no, I think I can go ahead and call this the end of the webinar.
Thank you, Jun. I think.
Thank you, John.
That's all.
Okay, so it's about time to finish for today. Thank you both, Dr. Kirapan and Dr. Chu. And thank you again, everyone, for joining today's CLAAS Connect Irreparable Rotator Cuff Tears Advanced Case Study webinar. CONMED has more webinars in store in 2022, so do stay tuned for the upcoming events. Please stay safe, Merry Christmas, and have a Happy New Year, everyone. Thank you.
Thank you. Good night. Bye-bye.
Good night. Bye-bye.
Goodbye. Thank you.
Thank you.